Good evening, everyone, and welcome to this Prostate Cancer UK webinar titled Living Well During and After Radiotherapy. My name is Jonathan Kay, and I'm the Health Information Service Lead at Prostate Cancer UK. I'll be the host for the evening, but before I get going on this properly, I just wanted to do a little bit of housekeeping for everyone. Apologies if you've already attended one of our webinars in the past. It's going to be very similar, so I'll try and get through it as quickly as possible. So first off, do you want to say you'll probably have realized we're on a Zoom webinar here rather than a Zoom meeting call. This means that you'll only be able to hear the speakers and see their cameras. Your camera and your microphones have been disabled, so you're free to chat through and talk about anything in the background without disturbing us. That's completely fine. As we're going through, if you've got any questions for the panel, please use the Q&A function to submit them, which should be available on your screen in the one of the bottom corners. I'm very glad that we've got Emma, Grace, and Vicky from our amazing specialist nurses team on hand to respond to some of these in the chat. We'll also have some dedicated Q&A time at the end of the webinar, where we'll go through some of the more detailed questions with the panel. Just a word of warning, please don't include detailed personal health information in your question, otherwise we won't be able to answer it. We can't give any health advice on individual cases, and also please note that the answers will appear in the chat once the questions have been answered with the nurses. We're sorry if we don't get to your questions this evening. If you're left with any urgent questions, remember the specialist nurses service is available Monday to Friday, 9 a.m. to 5 p.m. We'll aim to collate any unanswered questions and answer them in a summary email in the coming days if we need to do. Please note that everything in this webinar is intended as general information for men who are either considering radiotherapy or for men who are living with and after the side effects of radiotherapy treatment. And this information is meant to guide and help you navigate your situation better, and it doesn't constitute medical advice. Finally, and importantly, we'll be covering issues that some of you might find challenging or distressing. If this is the case, feel free to switch off at any point. We will be recording the webinar so you can come back and listen to this at any point. So, housekeeping out of the way, I'm now delighted to be joined by a wonderful panel encompassing clinical expertise and lived experience. I'll let them introduce themselves one by one. So, Pat, over to you.
Good evening, everyone. My name's Patricia, and I'm one of the specialist nurses that works at Prostate Cancer UK. And I've worked at Prostate Cancer UK for a number of years now. And my job is giving information and support to anyone who's concerned about prostate cancer.
Thank you. And I'll now pass you over to Steve.
Good evening, folks. I'm Stephen Shaw. I'm a guy that's been through the radiotherapy in 2020 and living well with it at the moment in time.
And finally, Phil.
Good evening, everyone. I'm Philip Reynolds. I'm a consultant therapeutic radiographer specialising in prostate cancer from Clatterbridge Hospital, and I've been looking after patients having radiotherapy for sort of the last 20 years or so.
Thank you. So Pat will be back in with our first talk very soon, but first off, I'd just like to do a quick poll so that we get a bit of a feel for the audience that we have with us today. So if you just bear with me 1 second, I will bring up the poll. So hopefully this has appeared on your screen now, but we're basically just asking, want to know more about our audience today so that we can improve our future webinar content. Please can you select any of the below options that apply to you? So we've got people deciding if radiotherapy is the right option for them, anybody who's currently going through radiotherapy treatment for prostate cancer, those of you who have had radiotherapy treatment for prostate cancer in the past and are probably still dealing with some of the side effects, if you're supporting anyone living with prostate cancer, and if you're a healthcare professional. So I'll just let that run for a few minutes. There's 112 of you in the webinar at the moment, and just over 3/4 of you answered. So I'll end the poll there. Hopefully you can see that. So yeah, we've got a good mix of men living with and after radiotherapy treatment. So thank you for that. So during this webinar, you'll hear about the different types of radiotherapy that are available to men with prostate cancer. You'll hear about some of the side effects they can cause and ways to help you come to terms with them. We'll also talk about the various forms of support that are available to you. This can range from support services like those offered by Prostate Cancer UK, but can also be other forms of support, including those from friends and family and men going through the same experiences. So I'm now going to pass you over to Patricia, our clinical nurse specialist, for her talk. Over to you, Patricia.
Good evening again. I'm just going to do a fairly brief overview of radiotherapy treatment and what it involves and the different types. So firstly, to say that radiotherapy is a very well tried and tested treatment for prostate cancer and works very well and is a very common way of treating prostate cancer. Basically, it uses high energy X-rays to kill cancer cells, and it can be delivered in a number of different forms. Well, this will very much depend on each clinical situation. For example, the grading of the cancer or the staging of the cancer, pre-existing medical condition, and the preference of the patient as well. Okay, I think we go on to the next slide. So how does radiotherapy work? Well, we know that radiotherapy works by damaging the DNA or the genetic or the blueprint part of the cancer cells, preventing them from replicating and growing. Cancer cells, they continue to die off over weeks or months after the treatment's complete. So the effects of radiotherapy keep on working. The aim of radiotherapy is to deliver the maximum dose of radiation into the cancer while minimizing exposure to surrounding tissues and organs such as the bowel and bladder. So radiotherapy for prostate cancer can be used virtually every stage of prostate cancer. It can be curative and used to treat localized or locally advanced prostate cancer, where the aim is to get rid of the cancer. For more aggressive disease or locally advanced disease, the pelvis, lymph nodes may be treated as well. Can be used as a salvage treatment, so it can be used if there's remaining cancer or recurrence after another first-line treatment, as for example, after radical prostatectomy, which is surgery to remove the prostate. Then radiotherapy can be delivered to the prostate bed, that's the area where the prostate gland used to be, or even to areas of the pelvis, such as the lymph nodes. Can also be given for advanced metastatic disease with the aim of slowing down the cancer. There is some evidence from a study called Stampede that men with metastatic disease may benefit from radiotherapy to the prostate only, but this is with the aim of slowing down the cancer, and that's not curative. It can also be used as a palliative treatment for advanced metastatic disease, as for example, treating painful bone metastases. So probably the most usual form of radiotherapy that's used is external beam radiotherapy for prostate cancer. So this involves treating the prostate cancer with a machine outside of the body, which generates high energy X-rays, and the beams of radiation are focused onto the target area. So the machine, you probably hear it called a LINAC or linear accelerator. And the beams come out of part of the machine called the gantry, which you can see in the picture there, is that round bit that rotates around the patient. So treatment is usually given 5 days a week, and each treatment lasts around 10 to 15 minutes. Actually, having the radiotherapy itself is probably only a few minutes, but you're actually in the treatment room for about 10 to 15 minutes. It's non-invasive, so it's usually not a problem to carry on with your normal activities, so such as driving or working sometimes or whatever you want to do. So I say it's non-invasive, and so it's a painless treatment, although it's very common to develop some bowel and bladder side effects, especially in the short term. So they tend to start around the middle of treatment and continue for several weeks after the treatment's complete. So when you're having external beam radiotherapy, it would be very usual for you to be asked to have a full bladder and an empty bowel in preparation for each session. So enemas are often used to help you to empty your bowel, and sometimes dietary changes can be recommended, although we do tend to find that this varies, so we would always recommend that you speak to your treatment centre about that. And the aim of this is really to reduce bloating in the bowel. So it helps keep the prostate in the same position for each treatment. The prostate can be quite mobile, really. So this helps improve accuracy and reduce the risk of side effects. Okay, and actually just to mention, because we do get asked this a lot, actually with external beam radiotherapy, the radiation doesn't stay in the body after treatment. So you're not radioactive, so you're quite safe to be around family and friends afterwards. Okay, so with radiotherapy, the beams that are generated from the machine, they have to penetrate through the body to reach the target site, and they continue to travel past the target site. So this is why you do tend to get a dose, an entry and exit dose of radiation, which is why side effects occur because they affect the surrounding organs. So EBRT is designed for each individual patient and is given by shaping the beams and pointing a number of these beams at the target area. So where the beams overlap at the target area, that's where the highest dose is given. Outside that area, the dose is considerably lower, and you could really compare this. It's a bit like pointing spotlights at an actor on the stage. Okay. So there are different types of external beam radiotherapy. The one that's most usually used these days is intensity modulated radiotherapy, which uses computer planning systems to help produce precise, complex target shapes. It also it is capable of delivering different doses into the same target area. And this is really the standard that would be used in most centres for treating prostate cancer with radiotherapy. Okay, so we know that prostate cancer responds very well to high doses of radiation. So hypofractionation is a term you might hear, which really refers to higher doses of radiation being given per session in fewer treatments. So if you speak to men from several years ago, they probably would have had their radiotherapy treatment over about 7.5 weeks. And this was because at that time the dose would be 2 grays on a daily basis, Mondays to Fridays, and that would be for 37 days or 37 fractions. We call each session a fraction, and the dose of radiation is referred to as grays. So then a study was conducted which looked at putting higher doses into the daily sessions, which compared only 20 days or fractions of a higher dose, 3 grays. The total dose was slightly less because higher doses were being given every day. And the results of that showed that the shorter course was found to be as effective as the longer course. So now that has really become the standard regime. It's just that if you speak to other men, they may have had a different type of a different duration of treatment. That's probably why from a few years back. But this also can vary as well, depending on whether they need to treat the pelvis and lymph nodes. In addition, you might hear about image-guided radiotherapy. And this really refers to daily imaging, for example, with CT scans or X-rays, which are given immediately before or during the treatment just to precisely locate the position of the prostate and make necessary adjustments. This is because of the movement of the prostate. Sometimes fiducial markers or placement of small gold seeds into the prostate under a local anesthetic are carried out prior to commencing the course of treatment, usually with the planning. And these really just act as anatomical markers to help guide the X-ray treatment. We do get a lot of questions about SABR, or stereotactic radiotherapy, stereotactic body radiotherapy. So this is a very precise form of radiation that targets the cancer from lots of different angles. So this can be delivered on a LINAC machine, but you probably will hear about standard specialized delivery systems known by their brand names, such as CyberKnife. There's a picture there of, I think, the CyberKnife machine where the linear accelerator is on the robotic arm and moves around the patient. So with this treatment, the doses are much higher because it's so targeted. So there's less danger, in theory, to surrounding tissue. So this can be given in very few sessions, between 1 and 8 sessions. And that's what they call ultra hypofractionation. So this isn't really yet standard in the NHS, and the availability of this really depends on what's available locally, the technology and the expertise. So we often get asked which is better, and we get asked should we be seeking this stereotactic radiotherapy. So one study that looked to find out this, it was called the PACE-B study. So this study looked at men with low to intermediate risk prostate cancer who had either conventional radiotherapy or SABR. So the results suggested that the SABR was just as effective as conventional radiotherapy in treating prostate cancer, and that this could be delivered effectively with much fewer appointments. So it's worth noting that on this study, because the men were fairly low risk to intermediate risk, that hormone therapy wasn't used. So really, we couldn't really say that it's better or worse or the same. It does seem to be very similar, but it's just that it's more convenient for the health service and it's more convenient for the patient. So that does appeal to a lot of men, that they're not having to travel to hospital every day for 4 weeks. But probably what's needed is more research to look at the results over the long term, over many years. And there are further studies also looking at more high-risk disease to see how it compares with standard radiotherapy. Okay. The other type of radiotherapy treatment that is used for prostate cancer is a type of treatment called brachytherapy, which involves treating prostate cancer from the inside rather from the outside in, as with external beam radiotherapy. So there are 2 forms of brachytherapy. So the first form of brachytherapy that I'm going to mention is called low dose rate brachytherapy, sometimes called permanent seed brachytherapy. With this treatment, small radioactive seeds, the size of a grain of rice, are placed into the prostate under anesthetic, usually a general anesthetic. And these are placed into the prostate through the skin, through the perineum, the area between the scrotum and the back passage. So the seeds themselves are made of titanium usually, and the radiation is inside the seeds. So the seeds lose their radioactivity over time, but the metal part component of the seed remains in place permanently. So this is a treatment that might be suitable for men with low to intermediate risk prostate cancer. In some selected cases, it may be used alongside external beam radiotherapy. Just to say as well that there's usually some precautions that need to be taken because the radiation is inside the body still for several months. Probably small risk, but usually you would be given some advice about things to be careful about and things to avoid. The other type of brachytherapy that's sometimes used is called high dose rate brachytherapy, or sometimes that's called temporary brachytherapy. So with this one, the thin hollow needles are placed into the prostate under anesthetic again to deliver radiation directly into the prostate. Again, those needles are placed through the skin, through the perineum. So with this one, no radiation is left inside because after the procedure's finished, the needles are taken out. And the source of radiation for this one is a small pellet that's mounted on the end of a cable, which travels down each needle in turn by remote control. And when it's finished, the pellet is retracted back into a machine on the outside. So this one is more often used for high risk or locally advanced prostate cancer. And it's often given as a boost to a course of external beam radiotherapy to get higher dose into the prostate. So the advantage of brachytherapy is that it doesn't have to travel through the body as external beam radiotherapy does. So the side effects are thought to be reduced. Although having said that, it can be a bit severe on urinary side effects, and you may well be given medications such as tamsulosin to help with urinary symptoms after this treatment for a while. So that concludes the most common forms of radiotherapy for prostate cancer. And we're going back to Jonathan now.
Thank you so much, Patricia. Yeah, it was a really brilliant introductory talk, and you've done a really good job of showing all the different variations of radiotherapy that are available to men. So thank you for that. I'm now going to reintroduce Steve back to the webinar. And we're going to have a bit of a chat around his experiences of living with and after prostate cancer. So Steve was diagnosed with stage 3 prostate cancer in 2019 following a routine checkup with his GP. He later went on to have hormone therapy and radiotherapy as part of the Stampede clinical trial. Steve lives in Nottinghamshire and has 4 children and 3 grandchildren who have all played an important role in his recovery, as we'll hear about shortly. So welcome, Steve. How are you tonight?
I'm fine, Jonathan. Good evening, everybody. Yes, I'm very good. Thank you.
Excellent. So just to start things off, if you could just tell us a little bit more about how you were diagnosed with prostate cancer.
I went on to my doctor's in about April 2019. I've been suffering with some shoulder pain for quite a long time, and I've been putting it off. And I went to see my doctor, and we got talking about what we could do about going to pain management clinic and everything else. As I come to the end of the session, I get up to walk out, and she actually said to me, "Is there anything else I would like to talk about today?" And I mentioned that I'd had a couple of occasions over the last few months of erectile dysfunction, which the question came back, is it when you've been out for a few beers, or and could you specifically put it? And which the answer was no, I hadn't. So she asked me to see if I'd want to, well, go and have a PSA test, which I'd had one in 2012, which came back okay. And she said to me, "We'll get the PSA test done for you, and within a week, you'll come back and see my husband, who was also a GP at the doctor's." But within 2 days, I got a telephone call from her husband asking me to go in within 2 days. The first consultation with Mr. Dickinson was not one of those pleasant conversations. He didn't say I'd got cancer, prostate cancer, but he intimated it could be because the PSA level come back at 13.6. I had the internal examination there and then. For people out there, I did actually faint at that time. Not with that, with the news of prostate cancer. And so the next thing I know, I was in this 2-week cycle of being put into the hospital, into Nottingham City Hospital, the urology department, with all the scans and everything else that come along, and the biopsies. Then I believe that they're different now from when I had them done. And unfortunately for myself, the biopsies showed that I got a high-risk prostate cancer with a Gleason score of 8, and I was stage 3. So the first oncologist I seen was a young gentleman that asked me to start taking some tablets. But within a week, or the following Wednesday, I got a telephone call from the City Hospital again, and another consultant wanted to see me regarding my diagnosis. So I went to see this guy, and he asked me to go in and see him in the room. And when we were going to walk into the room, there was my wife, and there was probably 7 people inside the room as well. And I did have to say to Mr. Chadwick, do all these people need to be here? Because I was a bit overwhelmed. I knew I'd got prostate cancer, and now I didn't know how to react with people all being around me. And he said to me, every one of these people here is going to play a part in your treatment, Stephen. What we're going to do, and these are his words, was we're going to go for curative treatment. So what I'm going to do is 6 sessions of chemotherapy. That's the only thing I heard, Jonathan. The 37 sessions of radiotherapy and the 3 years on the hormone treatment. It wasn't like I told him that I actually picked up on that. Well, my daughter said to me in the conservatory, when do you start the radiotherapy? And I just said, no, I'm having chemotherapy. And by then I lost the plot. So I had to have 6 sessions of chemo, but we had to cut that one short, one cycle, because it's left me now with issues with my finger ends, and it's left me with issues with my feet. As I'm sitting now, to be truthful with you, I'm sitting with my feet inside a pillow. My feet are very cold all the time. It's damaged nerves which cannot be replaced back in. But we went on, and then I was offered the chance to go on the Stampede trial, which, again, you have to go through certain tests to go on the trial. And all my test work came back good, which I always thought it would do, because I was a very fit, healthy guy at 60 years of age for my age, and playing non-league football right up to 37, 38. Never smoked in my life and never drunk alcohol till I was 30. And then all of a sudden somebody tells you that you've got prostate cancer stage 3, and given that it could be 24 months living, it was very, very, very hard to take, and from where I was then to now is totally different, Jonathan. Totally different.
Yeah, I mean, I can imagine that must have been a very challenging experience, and even that is completely understating it. I mean, from our previous conversations that we've had prior to this webinar, I know you've said in your own words you're a man who bottles things up and doesn't really ask for help. I mean, how did you feel going through that period, and who did you get support from?
I think that was, there's one thing that resonates with me, Jonathan. I'll always say this. I'm a man, the people know me, that I was a production manager for 30 years. I had 162 people report to me. So I was and I've always been a man that you don't show emotion and stuff like that. But also this came along and knocked me. And I can always remember my oncologist nurse saying to me, Stephen, you're no longer in control. We are in control of you now to get things better. And I found that very, very, very hard. The fact that I didn't want to tell the children straight away, and I come home and said, look, we need to speak to them straight away, and let's get this out there. And when you say physically, I don't know what, I was just shaken. I was just absolutely shaken. I was petrified, because the first thing when somebody says to you, and I'll say this now, when anybody uses the word cancer, the first thing you think on is death. Even though things have moved on from years and years ago, and treatments have got better, and you read about it, and I read about it a lot now. But when it's you sitting opposite somebody and they're giving you that news, it's devastating. And I relied on my wife. She's absolutely been a brick for all this for me. Really, as somebody that she doesn't go hot or cold. Everything's taken, and let's take one step at a time. My children, after the first initial thing of it, we're going to be okay, Dad. We're going to, and you never come for help before, but let's go through this together. And my outer family, my wife's family, and my family, they all sort of like rallied round, and and you think this is going to be something that'll happen just for a couple of days, 3 days, but no, the encouragement it gave me a lot of encouragement, because there were some days I didn't know what to do. I went into Maggie's Centre, which is based in Nottingham. I couldn't get enough of people talking, so I picked the phone up to Prostate Cancer UK, and I spoke to one of the nurses there, and I'm not just, it was absolutely fantastic. She must have called me back in set times. She set times, and she called me back within stages over weeks. And each day she said she'd ring me at a time. My phone rung at that time. Very consulting, very, helping me through things. I've talked to her about, the treatment I was having, the way my sexual life's going to be, and everything else that goes around it. It's no use, people look away and think, oh, I don't want to ask that question. You need to ask this question, because if it doesn't, and you get the encouragement and the thing that comes with it. But one thing that the nurses always used to say to me is, Stephen, let's take one step at a time, because I'm somebody who wants to be halfway around the Aintree course before, the women are coming along and say to me, Stephen, let's just take one step at a time. Breathe, think about this, and it was so professional, fantastic. Yes,
that's really good to hear. And yeah, I think a lot of the things you're saying there will be resonating with a lot of our audience that are listening to that right now. Just that idea of just one step at a time, trying to control what you can control, and not thinking about so many different possibilities, the bigger picture, just focusing there and then. Can I just go back to, you've already covered a little bit of some of the treatments that you had, but it's around the fact that you joined a clinical trial. What made you decide clinical trial was the right thing for you?
I think, Jonathan, in one way, as I said in the past, it was sort of like taken out of my hands a little bit, because when I went back to see Mr. Chadwick, and he was in the room there, and it was with all these people, and I said, as I said to you on, he said to me, what we're going to go for here, and I always remember his words was curative treatment. They stick with me, curative. This, I got a chance, as he said, because of my background and health and stuff like that, I got a chance to cure this. So when he put this to me, and I'm being brutally honest, I never questioned about any of the treatments. I just thought, this guy knows what he's doing. Let's just go along with this and text each step, because every 3 weeks when you've had your chemo, you go back to see him and you do all this kind of thing. But so I was accepted. Like I said earlier, I wasn't. When I went to have my heart checked out, my lungs, I knew personally before I got there that I was going to be fit enough to pass this. And then it came back that I've been accepted on the Stampede trial. They explained to me that this was the patches that, slow releasing. I'd start off with 4 of these patches on the back and your shoulder and stuff, till it got down to 3 once the testosterone level started dropping down, which they dropped down pretty quickly, to the extent that at one time I was at 0.01. So I've got no inner strength and no, I carried on going to work, but every day it was like me saying to somebody, I wanted to push them 2 barrels of coal up a grade 1 hill. It really was. That was the treatment. Then I finished the chemo, and then I went on to the radiotherapy in the January, which again, it's, as Patricia spoke about, the radiotherapy, I found it to be at times challenging when I got into in the arena with all the other people. First off, I kept myself to myself. Just went in there. You had to, you've done the treatment, pre-treatment, the enemas and stuff to go in there, and then you got to drink the water. And there's times when sometimes you've drunk the water and there's been a backlog and you're not going to go in at that same time. And sometimes you could be in that area for 3.5 hours for this 10-minute thing. So it made me take my hat off and start speaking to more people, more men. What I didn't want to do is start saying, well, I've asked you this. I didn't want to get into that situation, but I found it a lot more. I've been able to talk to other people around it, about what they were going through. How did they find their radiotherapy? How did they? And it got to the point where going through the 37 sessions that I did look forward to going some mornings then, or in the afternoons, whenever my time was. There's never a set time, and because you're sort of like seeing the same people, and it was encouraging to, all these people was together. We're all going to go through the same scenario. I think there were just times when other things came in for that radiotherapy, and you looked at people, and it used to make me feel very vulnerable, very, very vulnerable at the time.
Mm.
Having said that, the radiotherapy people at City Hospital at Nottingham, every one of them were very encouraging people, very, very encouraging people.
I think you touched on something that's very important there. I think that kind of sense of camaraderie, that sense of connecting with other men going through something at the same time can be really powerful, for your support mechanism, your ability to cope with the situation. And I think hearing what you've been just saying then, the different treatments you have, highlights a very important thing as well. It's the fact that, yes, some men will just have radiotherapy, but quite often radiotherapy is part of a wider treatment regime, that some men will have radiotherapy, they'll have it at the same time or before they then start hormone therapy. So I think it's really important for men on the call to hear that kind of thing. Could you just talk a little bit more about some of the side effects that you had in particular from radiotherapy?
For radiotherapy, I used to find my radiotherapy side effects, maybe because I was having the same time as the hormone treatment, same time. I used to find fatigueness. I used to find it, like I say about being down there for 2 or 3 hours, I found it draining. It was like an everyday city hospital. Very, very draining. I had some stomach issues in the early parts of my radiotherapy. I was sent for some more blood tests to make sure that there was nothing wrong with the spleen and stuff like that. I used to find with the treatment, urination, just after I'd had the treatment, I used to find urination very hard for a few hours, going to the toilet, but that eased off, going back to something that Patricia said. I was diagnosed with some tamsulosin tablets. That did help that part of it. And I thought I'd come through it all very well until last year, which it seemed a long time since I had my radiotherapy, that I did my normal stool sample in June of last year, which every 2 years now, being the age I am, you do. It came back fine. I've been having some stomach issues since last September again, come up, and it was really very painful and very. So I went back to my doctors, who asked me to do another sample. It came back high in protein. So that sort of like triggered another thing with them, saying, well, let's have a look at this. And it got to just a week before Christmas that I had to do another stool sample, sent off, and it come back that they found blood in my stool. I was given this news on Christmas Eve, at the same time that the pharmacy guy brought me some, tablets? I forget the name of the tablets now. Iron tablets. He bought me the iron tablets out, and I had to wait over the Christmas period to go and have a colonoscopy. And during that time, they found that I'd had some damage from the radiotherapy to my rectum at the back, which had been causing some of the bleeding when you force sometimes and you don't force. So there was nothing apart from the pain of this and the blood and the worry. It was a side effect of, I think they call it radiation I can't pronounce that one, but they call it something like that, ptosis. So yeah, that was my journey through radiotherapy.
Great, thank you. And then my last question now is kind of moving forward to today. I mean, it's been 7 years since your initial diagnosis. We're all really glad to see that you're still here. Can you just tell us, just how are you feeling on yourself? How are your family doing now? Do you feel
very
like
good?
Yeah,
very good. I mean, I don't think the weird. I think people, when I was first diagnosed, and I've been well for the last, living with, if people had heard other people in the family or somebody, or knowing somebody had got cancer, they'd never talk around me. And they were sort of like skipping that, didn't want to bring that subject up back around me, especially if Anne had been out shopping and she'd seen somebody and said, oh, did you know such and such? And then I'd find out later, say, Dan, did you know? Yeah. And I think, well, why didn't you, well, it doesn't matter, and then you realise that people are moving around you and you think, well, this has got to stop, end of the day. I want people to be normal, and you face life every day. I think every day, people always say to you, cancer diagnosis change you. It didn't for me for the first 2 years, I must admit. It didn't change me, my outlook on life, how it was dread. But the last few years, it's been one of, and I don't think it's like you think, oh, it's given me a second chance, because all the treatment, it has given me a chance, because I think it had gone much longer, we would have been talking the same conversation we're having now. But there's not many days now that I think back to myself, well, I went through a lot. I sort of like, I try to put it away and just concentrate on being, and any advice I'll give to anybody at the time is listen to your people around you. Listen to the doctors. Listen. And I encourage people now, even if I talk to people now, I say to them, pick a phone up, ring Prostate Cancer UK, if it's this kind of thing. Or if there's any other cancer somebody talks about, pick a phone up. There's somebody at the end of the line to talk to. When you go and see your oncologist and your oncologist nurse, don't be frightened to ask a question. Don't be frightened of the answer either, because you have to live with the answer. And it's no use people butchering something up for you to walk away. And then, I said to my oncologist, I want you to be straight with me from day one. Every time I come in, I want you to be straight with me, because I can only deal with that kind of thing. And that's where I deal with life. It's no use telling me something, then 2 weeks later you're telling me a different thing. Let's get it into there.
great. I mean, that's very sound advice. Thank you, Steve. You're going to be sticking around for the Q&A session at the end, yep. So people listening, if you've got any questions that you'd like to ask Steve, get them in the chat. But
Jonathan, can I just say one thing?
Yeah.
In case anybody out there wondering, I couldn't have my prostate taken away because cancer had already spread out my prostate into my lymph nodes at the back of our back. And also I had a small shadow in my tummy as well, which my oncologist thought that it wasn't that. But when he did the imaging again after the chemo and that had gone. So he was sure that was parts of cancer as well.
Okay. Thank you for that clarification. Okay, like we said, you're sticking around for the Q&As
Yeah.
at the end, so if you've got any questions for Steve, get them into the chat now. We're now going to move on to Phil Reynolds' talk. So his slides are just being loaded up now. Phil is a consultant therapeutic radiographer. He specializes in the care of people having radiotherapy for prostate cancer and has gained an MSc in prostate cancer care. For the last 8 years, he's been working as a radiographer in prostate cancer at the Clatterbridge Cancer Centre in Liverpool. He's also an honorary lecturer at the University of Liverpool and ambassador for the Radiotherapy UK charity. Phil's also a prostate cancer UK clinical champion and a member of an exercise oncology program looking at integrating exercise oncology into prostate cancer care. So it's fair to say he's done an awful lot for men with prostate cancer and an awful lot for us as a charity, and we really appreciate him giving up his time to do his talk now. So I will now hand over to Phil.
Lovely. Thank you, Jonathan. Thank you to Prostate Cancer UK for inviting me to talk, and good evening to everybody listening. So over the next few slides, I'm going to talk about those living with and after radiotherapy. What I'm hoping to cover today is sort of what to expect during your treatment, how to manage the physical side effects. I'm going to talk a little bit about emotional well-being, give you some lifestyle strategies that can help, and then talk a bit about what happens at follow-up. So we know radiotherapy is a very good, very effective, highly effective treatment, on a par with surgery, depending on, the kind of cancer that you present with. If you can have surgery, then you're probably eligible for radiotherapy as well. And they are good, effective treatments, as good as each other. But like with any treatments, there are possible side effects. Unfortunately, nothing comes cost-free. So I'm going to talk a bit about the side effects now. So we know with radiotherapy, it is a targeted treatment. So where you're treating is where you get side effects. And next to your prostate, I'm sure you're all aware, sits your bladder and your rectum. So these are the bits that, as much as we try to avoid, we catch a bit of with radiotherapy. And the most common side effects you can see here. So this is taken from the RCR, so the Royal College of Radiologists website. This is a standard consent form that should be used across the country. Departments have adapted them slightly for each department, but in essence, they all say the same thing. So this can be downloaded from the RCR website if you wanted to have a look at it as well. So the most common things you see are the tiredness and problems with your waterworks and generally your bowels as well, but more waterworks, so peeing more often, getting up at night, slowing down the flow. So this is why when you see your oncologist, they will ask you about your waterworks, and ideally you want to have reasonably good waterworks before the radiotherapy starts because they can get worse. So you may be referred back to urology. You may need a TURP, a little coring out procedure for prostate to help with flow and help you emptying, to try and optimize your waterworks before you have the radiotherapy. You can also get bowel problems, which are common with radiotherapy. So again, more frequent. Some people get a bit soft. Some people get constipation. Some people find that every 2 days, every day is slightly different with radiotherapy. And then you may get some pain and discomfort. You may find that you get some blood from the back passage, or even blood in the water as well. These are more or less common, but they can happen. And if they're happening through treatment and they're not too bothersome, generally not much is done about it. The rare side effects are urinary tension, and the need for a catheter is quite rare with radiotherapy unless you have really bad waterworks already, or you may have had your prostate removed and are then having radiotherapy after surgery. So you may already have an element of incontinence. So it's quite rare to need a catheter then, but it can still happen. And just general incontinence is, again, quite rare. So these are the short-term early side effects that tend to happen during and then for a few months after treatment. Let's move on, please. But unfortunately, with radiotherapy, there are risks of what we call late effects as well, and possible permanent changes after radiotherapy. So some of the changes that you get to your waterworks or your bowels may be permanent, and you may not get any changes for many months or even years after radiotherapy. The side effects of radiotherapy can continue for a number of months. Most people settle back down within a few months, but the effects of the radiation can be ongoing within the body for a couple of years. If you're having your pelvis treated, so your pelvic lymph nodes treated as well, then there are risks of lymphedema, so some swelling of the groin and the lower limbs, and possible nerve damage as well. So, we are also going through bone. So the bulk of the dose with radiotherapy is obviously in the middle where your prostate is. But again, if you've got long-term bone issues, you do need to be careful, and you may be advised to get some bone strengthening as well, because we know that hormone therapy can also affect your bone density. Just move on, please. So as we've alluded to, as a general rule of thumb, and this is, everybody's different when it comes to side effects, they tend to start from about halfway onwards. But some people get the side effects earlier, some people get them later, and some people are very lucky and get nothing at all. But the peak of side effects, you need to be wary, can be a number of weeks after your treatment. So don't be surprised if things get a wee bit worse before they get better once you finish. And then recovery can be, some people are better within a couple of months. Some people, 3, 4, 5, even 6 months afterwards are still getting over the effects of their radiotherapy. So again, it's not uncommon to still have some ongoing effects many months later, but hopefully over time you will start to see them improve. And as we've said already, late effects can happen many months or even years afterwards, because the effects of the radiation on the body actually is ongoing for really a couple of years. And also, a lot of people may be on long-term hormone therapy as well. So that in combination, you're still feeling tired, you've still got the sexual problems. One of the late effects of radiotherapy, just to compound those people on hormone therapy, is sort of 18 to 24 months after radiotherapy, you may find you can lose your erections completely. So these people now are having radiotherapy without hormone therapy, generally don't get any problems with their erectile function in the short term, but can happen, many months or even a couple of years later. So just moving on, please. So what can you do to help? So bladder training is good. So if you have been advised by your department that you're going to need to hold a certain volume of fluid in your bladder, I know there's about half a dozen departments across the country that don't use bladder filling, but the majority of I think there's around 55 radiotherapy departments or something in the country. The majority of them do ask you to hold a certain volume in your bladder. So if you know you're having radiotherapy and you're struggling, the best thing to do is just practice. You can train your bladder to hold the fluid. So if you've been advised to say, you're going to need to hold, say, 200 or 300 mils in your bladder for 30 or 40 minutes. If you can hold half a litre in your bladder for an hour, then that should make the radiotherapy easier. So it's about training your bladder. If you can't hold half a litre, from the start, maybe start with 100 mils, just build it up as well. Pelvic floor exercises will help your bladder control. It can help with sexual function as well, but you've got to do them regularly. So I do advise people, there's an app, whether you get your apps called the Squeezy app, which has been devised by physiotherapists. So it is an NHS supported app. I think unfortunately there is a cost to it. I think it's $2.99 last I checked, but it does give you reminders and instructions on how to do the pelvic floor exercises properly. I think PC UK also have some information on the pelvic floor exercises, so it's worth starting them as well prior to your radiotherapy. And even there's no point you should be starting them. Even if you start them through the treatment, it will help as well. Good hydration is paramount. A lot of people, and instinctively you think if you pee more often, to stop drinking or reduce your fluid intake. That's about the worst thing you can do, because what happens is the urine that sits in the bladder can become very concentrated, and it irritates the bladder and it makes you go to the toilet more often. So you may just pass small amounts, little and often. So being well hydrated does help, alongside reducing your caffeine intake, cutting back on your alcohol and fizzy drinks. These are all fluids that cause you to go to the toilet more often. And generally, you would not change your diet unless you've been advised to do so. So if you're getting problems with your bowels through the radiotherapy, you may be advised to reduce your fibre or increase, depending on which way you're going. All this is, ideally done alongside lots of fluid intake, lots of clear fluid. And I don't mean vodka or gin, ideally water. And if the sort of the lifestyle changes aren't helping, then it's medications. Tamsulosin, we've already heard about. A lot of people are on that before their radiotherapy anyway. It is a very good, effective medication for helping you empty your bladder. You can be on that medication lifelong if you need it. The only way to really know is just to stop it for a day or two and try without it to see if it's still necessary. You may also be prescribed medications to help with urgency and incontinence, things that help dry things up. You need to be wary with those medications because they dry things up. You can get constipation or a dry mouth with these medications, and they can be used in combination with tamsulosin as well. So you might have mixed waterworks problems that might need both medications. So again, you need to speak to whether that's your review radiographers or your clinical team through the radiotherapy, and they will be able to best advise you the best way to manage your side effects. So next slide, please. So I believe there's a talk with PC UK coming up on hormone therapy. So I'm just going to brush over this, talk about it very briefly, and talk about more about the sexual dysfunction. So hormone therapy in one form or another has been around for a very long time. It was initially done with castration. Nowadays, obviously, we do chemical castration, but there are lots of associated side effects from that, which I'm not going to go into detail because there is another webinar coming up, which you can, I'm sure, all join. So if we just move on to the next slide, please. So we know that sexual dysfunction, it's caused because of treatment. So radiotherapy can cause damage to the nerves. Obviously, there's a stress associated with a diagnosis of prostate cancer. Radiation and surgery can also affect blood flow, and your hormone therapy, if you're having that, is going to knock out your libido and your testosterone, also causing sexual dysfunction. Next slide, please. So this was a paper done by one of my colleagues at UCH, and this is patient-reported outcomes. So this was asking patients what they experienced through their prostate cancer treatments and what perspectives they have. So there's lots of things on here. Perhaps you might, your clinical team may not even ask sometimes. We do need better training. We all hold our hands up, talking about and opening up the conversations. But don't be afraid to ask these questions to your clinician. There's lots of things on here and lots of things that can be addressed with counselling, with medications, and good support. So just move on, please. But if you already have an element of erectile dysfunction before your prostate cancer treatment, unfortunately, we're not going to make it any better. So if you do have type 2 diabetes, you're hypertensive, you are overweight or have high cholesterol, certainly any problems with your heart, you're a smoker, and lots of medications as well may affect your libido and your sexual dysfunction anyway. So these are all things that, you can maybe manage or try and manage before your treatments, because unfortunately we know that hormone therapy is going to affect your weight. You're going to be tired, so you may not be as active, and it can then upset your cholesterol, your sugars, and things like that. So it's all about trying to get active, and I'll talk about the exercise shortly. So next slide, please. So how do we manage erectile dysfunction? So there was a paper written back in 2014. So it's quite old, but actually we do tend to follow the same algorithm. So treatment for erectile dysfunction is ideally started within the first 2 or 3 months of having any treatment, whatever that is. And that may be with simple lifestyle approaches, pelvic floor exercises, getting fitter, healthier. Then psychosexual counselling is very good, very effective, but we do know there's a real lack of counsellors across the country, certainly within the NHS. But the use of medication should ideally be done within the first few months of commencing treatments. Now, we as clinicians understand that when you first come to see us, your priority may not be your erectile function, and you want to treat your cancer. But we should be having those conversations up front and alluding to the fact that you're going to lose your erectile function and possibly your libido, and you want to be on these things sooner rather than later. But at your first appointment and when you're being consented for treatment, it is touched upon, but the patient's, your priority most of the time is not my erectile function, it's my treatments, and I want to live a long time. But it's important that you do have those conversations sooner rather than later about trying to treat your erectile function. So we tend to start with the medications, ideally a low daily dose of things like Viagra, Cialis. There's a couple of different ones out there, and that's used in combination with the vacuum pump. So when you talk to people about the vacuum pump and the idea of it, it puts them off. But if you have to think about the vacuum pump, it's sort of about rehabilitation for the penis, basically. It is exercise for your penis. And when you first get the pump, you use it by yourself every day, 10 minutes a day, pumping things up and down, and that will help the blood flow and the tissues around the penis remain strong. And then obviously it can be used in the bedroom as well, and that is best used alongside medications if you need them. They're the sort of first line things, and then if those things aren't working, you may need referral into urology or an andrology clinic to get some more specialist advice. So next slide, please. So what's often overlooked is, we can give you medications, we can give you the pump, and you may be able to get a big stonking erection, but actually you don't want to do anything with it. You've got this loss of libido, the biological need for sexual activity, your sex drive just goes out the window. Again, it's affected by certain things, your general health. If you're tired, lethargic, stressed, you may not be, the sex is at the back of your mind. And obviously, the hormone therapy as well is going to drive down your testosterone and affect your libido. So next slide, please. But it is difficult to treat. And I think it's important to try not to focus on erections and perhaps sexual intercourse. It can, if you're not able to perform in the bedroom, then that can hit your confidence. So it's about taking the focus off the orgasm and doing what they call sensate focus exercises, which is where you explore your partner. Basically, it's a bit like going back to being a teenager. You're holding hands, you're exploring each other's body, and the focus is not on sex or intercourse. You work your way up to that. There's various stages of sensate focus, but they all start with sort of trying to stay close in non-sexual ways, and then you lead into exploring each other's bodies. So again, as I say, it's like almost like going on a first date again, having a picnic, going to the pictures, whatever you want, but as I say, almost like being a teenager again and trying to find new activities and things that you can do yourself. We mentioned psychosexual counselling is very useful. CBT, but cognitive behavioural therapy, can also be very useful if you're really struggling, not just with loss of libido and erectile function, but with the side effects of hormone therapy. Obviously, there's a discussion to have with your clinician whether coming off your hormones may be in your best interest. If it's really affecting your quality of life, there's obviously a balance between treating your cancer and quality of life. And then, a few years ago, well, certainly when I first started doing this, if a patient was on testosterone supplementation, you'd stop it and they'd never go back on it. Well, the thinking is very different these days. So to bring people's testosterone back up, you may be offered testosterone replacement supplements, but that's generally done with your oncologist, but also more specialist help as well. So you might need a referral into a specialist clinic to discuss testosterone supplementation. Okay, next slide, please. So one of the things I was asked to talk about is the rectal spacer, which is become a bit of a buzzword over the last few years. They are offered in lots of centres now. Some centres don't offer them routinely to everyone. You need to perhaps have a history of a bowel problem, or you may have had colitis or IBS or some sort of a previous cancer where historically we couldn't give you radiotherapy, but now with the space, and the space is basically a big ball of water, if you like. It's a big gel filled with water that's put into the space between your prostate and your rectum. It is done under anaesthetic. Most places are moving towards local anaesthetic, but it's still an invasive procedure. It's very much like having a template biopsy, which I'm sure lots of you will be well aware of. So it is uncomfortable putting it in. There are risks. Obviously, the spacer goes in the right position. It is useful. It can help obviously reduce your bowel toxicity. There is evidence to say it can also help with your waterworks and your erectile dysfunction as well. So it's not suitable for everybody. And lots of centres, as I say, if it's something you wish to discuss, you need to discuss with your clinicians, because some centres don't offer it, so that you may need to be referred somewhere else. But you need to have that conversation up front with the specialists before you go off and get a spacer put in and then turn up in a radiotherapy department and they go, well, we can't treat you now. So it's a conversation to have with your clinicians, but lots of NHS departments do offer them, but there usually has to be a medical need for it. So, next slide, please. So one of the most common side effects of prostate cancer treatment, so not just radiotherapy, but combine that with hormone therapy, even after surgery, is obviously fatigue. The best thing you can do for your fatigue is not sit down, get up off your backside and do some exercise. So if you're used to doing lots of exercise, carry on. If you're not so used to doing it, just gentle exercise, a walk, a potter in the garden, just something to get you out the house, get the blood flowing, and try and do something every day. Obviously, there's the Prostate Cancer UK fatigue support service as well. The specialist nurses are excellent, but exercise is really the best thing that you can do for your tiredness. And obviously, everybody's different. Some people can exercise, some people can't, so you're very limited. So there are exercises people can do in their chairs, with walking sticks, all sorts of things. If you can't get on the floor and do a press up, you can do it against the wall or on the back of a chair, so that you can adapt exercise to yourself. Just next slide, please. And one thing we get asked a lot about, obviously, what should I be eating? The evidence is a little bit scant. They're mostly observational studies. There's a real lack of randomized controlled trials rather. Lots of people talk about lycopenes. So lycopenes are an antioxidant that's found in primarily tomatoes and people say that cooked tomatoes are better than raw tomatoes, but raw tomatoes are still very good. And there is evidence for lycopenes reducing the incidence of prostate cancer and helping with people who've had a diagnosis as well. Should you cut out all your meat and things like that? I'd say no. So we talk about plant forward rather than plant based. So introducing fruits and vegetables into your diet, having a good, well balanced diet, rather than cutting everything out. There's no evidence that soy worsens prostate cancer, and there's no one superfood. There's not one thing we could say, you will eat this, you're either not going to get prostate cancer or it will treat your prostate cancer. So it's all about having a good, healthy, well-balanced diet. I see lots of patients who talk about their well-balanced diets, but they're eating enough for 5 people. So it's not so much what you're eating, it's also your portion size as well. So you've got this plate on the right there, so that's how you should divide your plates. But again, not big, huge, massive dinner plates. With hormone therapy, you can put on weight. It can be difficult to lose weight. So you might just need to focus on maintaining your weight rather than losing weight, which can be very tricky if you're on hormones especially. So next slide, please. So this is a very recent paper. It came out a couple of months ago, and they looked at 19 studies for people having radiotherapy and talking about nutrition and lifestyle. So having good nutrition and a healthy lifestyle does obviously improve your weight control. It offered good cardiovascular control as well. It helps with your diabetes, your cholesterol. People with good healthy diets found that their bowel side effects were slightly less. But you do have to be careful. If you cut out a lot of your high energy foods, you're going to be tired. And if you cut out various, carbs or whatever, protein, whatever it may be, your nutritional status is not going to be as good. It is all about having a good, healthy, well-balanced diet. So this was an overview of 19 studies, but basically at the end of it, it said there's not enough evidence, definitive evidence. We need more randomized controls type trials. But living a good, healthy lifestyle is beneficial for not just your prostate cancer, but obviously just your general health and well-being. Next slide, please. So just going back to exercise, we know the benefits are huge. It can, as we've said, improve your overall general health, improve your quality of life, help you maintain your weight. It's good for the body, it's good for the soul. Getting out for a walk can perk you up, and it does help with the side effects of treatment, especially the fatigue, but also if you get loss of bone mineral density, so you get thinning of the bones or wasting of your muscles with your prostate cancer treatment, then doing both cardio and especially resistance exercise is very beneficial. There is a little bit of evidence now to say it does improve outcomes or helps alongside treatment to improve outcomes. It can improve your sexual function and just generally enhance your quality of life. And the bottom right article there, again, is relatively new. And it basically says, start exercising. There's no point you should be exercising. But if you get a diagnosis and you think that's the time you need to get fit, that is the time for you to get fit. If you're already fit and healthy beforehand, fantastic. But there's no point in your journey that's a bad point to start exercising. Next slide, please. But we do know that prehabilitation and rehabilitation are buzzwords as well. And the fitter and healthier you are before treatment, the better you will be. So prehab is about getting fit for treatment. So obviously if you're having surgery, you may be a bit limited in between the time of your diagnosis and when the surgery is. If you're having radiotherapy and hormone therapy, you may be on hormones for a few months. So you've got time to start getting fit and healthy. And then the rehabilitation. Rehabilitation has really been around in one form or another since the sort of the late 60s. It's sort of the word was first bandied about. And you can see from this diagram here that those that had prehab and rehab got back to their baseline much better. So those had prehab were fitter before their treatment started. They dipped through the treatments, but then carrying on rehab, you get back to your baseline much quicker. But you do, if you're on long-term hormone therapy, you've got to adjust what you can and can't do. You may not be able, if you're used to running 10K, you may only be able to run 7 or 8K, after your treatments. And, it's about not being downhearted, not getting upset that you can't quite do what you did before. But exercise is certainly very, very important. Next slide, please. So I'm sure lots of you are aware, obviously, Chris Hoy, the Olympic cyclist, was diagnosed with advanced prostate cancer a few years ago. And he teamed up with Pure Gym and the Royal Marsden, the Institute of Cancer Research. And if you have advanced or locally advanced and you're on long-term hormone therapy, you have a Pure Gym near you, you can either, just Google Pure Gym prostate cancer, you'll get this picture, and you can get 12 months of free gym membership, which, is not to be sniffed at. And they will also give you some help and introduce you to trainers. And so you get a program of exercise as well. So I would certainly advise anybody who has a Pure Gym close by to certainly look into this. Next slide, please. So just some practical tips with regard to the radiotherapy. Depending where you live, you may be able to drive, you may have parking, you may need to get public transport. So you need to plan your travel in advance, because you will be going anywhere from possibly 5 to 20 days for your treatment. Make sure you wear comfortable clothing, things that can be pulled down easily, because they will need to get to your pelvis to give you radiotherapy. They will cover up your modesty, but they will need to either take trousers off and pull your underwear down. And it's always worth asking about appointments to try and make them fit around you. Certainly lots of chaps are still working. So all departments will do their best to fit appointments around you. It's not always possible, but if you don't ask, you don't get. So we would advise, when you speak to your oncologist, say, I'd like a time around this time, if you can. You may well be in the department for anything up to an hour. Certainly if you've got to use an enema and fill your bladder, do all that preparation beforehand. So you may want to bring somebody with you to have a chat with. Steve said, when you start treatment, you tend to see lots of the same people in the waiting room. So you do build up a rapport and a bit of a camaraderie with other people. If that's for you, great. If it's not for you, you just want to sit down and read a book or a paper, absolutely fine. But it's worth bringing something with you. And if you do notice any changes in your side effects or you get any symptoms, note them down. You will see, on the whole, the same people every day through the radiotherapy. Lots of departments also have specialist review radiographers who are there to look after you and your side effects. But if you can keep a record of what's changing, then we can help you better manage it. You do also need to obviously lie flat and still on a treatment couch. I say couch very loosely, it's a hard bed. For sort of 10 to 15 minutes. So if you do need pain relief, then again, I would bring that with you, so to make sure you can lie comfortably. Next slide, please. But when you have a diagnosis, you go through any treatments, it is very normal to feel anxious and uncertain. Your mood may have dropped because of the diagnosis, but also your hormone therapy may have affected that. And certainly what we do find is you come every day for 4 weeks for treatment, and then next day you're not coming anymore. All of a sudden, you've had what feels like a full-time job for 4 weeks, and then you almost feel a bit forgotten because you may not be reviewed for sort of 2 or 3 months after your radiotherapy. So it is important, you do get this, to think about this sense of loss. But the radiotherapy department, the staff will always be there. There will always be somebody, whether that's a specialist nurse or somebody you can chat to after your radiotherapy, whether it's Prostate Cancer UK or Macmillan. So there's always somebody there to speak to. And it's important that you do talk and seek professional support if you need it. And remembering that seeking help is a strength, it's not a weakness. Asking for help is very important. Next slide, please. So just to say, it's important that you do keep active, try and maintain a healthy lifestyle as best you can. But if you do notice changes with your waterworks or your bowels after radiotherapy, mention it to your clinical team or your GP, and the referral can be considered to a more specialist team if need be, or they may be able to offer simple advice depending what's changed. Next slide, please. So overall, the side effects for most people are pretty manageable and tolerable. It's important that you are fitter and healthier you are, the better you will do with treatment. There's no one superfood, so a good, healthy, balanced diet, a little bit of what you like will not do you any harm. Try and reduce your alcohol if you can, because that will also upset your waterworks. But try ultimately enjoy your life. Do talk to others around you, and importantly, there's nothing you shouldn't do as you're going through radiotherapy. If you've got questions or concerns, ask your clinical team, ask the staff there. But you can carry on working, going out and about, spending time with your friends. There's nothing really you shouldn't do. But do remember that recovery does take time and it does affect everybody differently. Thank you very much. So just a few resources here. So obviously Prostate Cancer UK, we're all very aware of. The PRADA is the Pelvic Radiation Disease Association. So they are the sort of the go-to people if you're struggling with the late effects of treatments. They are fabulous. This is what they do. It's their bread and butter. They'll be able to advise you and maybe refer you or give you names of people who you could be referred to locally, or somebody maybe even outside of where you live will take referrals as well. So some radiotherapy departments have late effects clinic which do take external referrals, so they will be well aware of all of that as well. So, thank you very much.
Thank you so much, Phil. That was an amazing talk, and I'm sure there's so much, insightful advice and support that men will get from that talk. So thank you very much. Just before we start the Q&A session, I just want to invite back Patricia, who will just talk through on this slide some of the support services that are available through Prostate Cancer UK.
Okay, thank you, Jonathan. We just wanted to let you know about some of our services. So we have our nurse helpline, so you can speak to us Mondays to Fridays. Our helpline is open between 9 a.m. and 5 p.m. Wednesdays, it is 10 till 5 p.m. We also do speak to people on live chat, and we do also respond to emails. If you have inquiries that you prefer to email about, then that's also an option, and that can be done through our website. We also run a sexual support service, and if you're interested in finding out more about that or using the service, you can do that through our website, or you can phone us on the helpline and we can take your referral there. We have a lot of great publications which cover practically everything, which you can download or order from our website. We still send out paper copies, and that's free of charge. If you're not sure what publications you need, you can always phone us and we'll talk to you about that. We also run a one-to-one support service with our volunteers. So if you felt that you needed a bit of one-to-one support, or just to talk with somebody who's really experienced it, somebody who's been there, then you would have the opportunity to speak with one of our trained volunteers. That service can be accessed through our website or through our helpline. We can take your details and take your referral from there as well. We also have a very active online community that's very supportive to each other, that can be accessed through our website. One more service that's not on there is our monthly hormone therapy classes, or ADT classes, they're called. We call them the lowdown. So you can find out about those hormone therapy classes on our website and sign up for those online as well.
Thank you, Patricia. So now we move into our Q&A session. We're overrunning slightly on time, but we should have enough time to to get a few questions in. So I think all the panelists will be appearing on screen now. I can kick things off with the first question, and I think this is probably one for Phil or maybe Patricia, but how will I know what kind of radiotherapy is right for me? It's a very open-ended question.
Yeah. So it's a chat to have with your oncologist. So it does depend on your stage and grade of cancer. So as Patricia said, the PACE study looked at low volume intermediate risk disease. So it was Gleason 3+4s, T2s, PSA less than 20. If you were 4+3, then you still need hormone therapy. But anything sort of less than that, you don't need hormone therapy. But it's about speaking to the oncologist and what's available locally. Some places won't offer SABR, some places won't have brachytherapy. So it's a chat to have with your oncologist and a referral to other centres if they think it would be of use.
Great, thank you, Phil. And then I think this one might be one for you, Patricia, and that is what happens if I'm unwell and I have to miss a treatment? I'm guessing that's something that have phoned up our nurses about on many an occasion.
Well, that happens sometimes. If you miss a day, then they'll just add another day onto your course of treatment. I mean, this happens like bank holidays and stuff, then, you could be missing a day because of a bank holiday. Longer periods of missing the treatment is probably not advisable, but if it's the odd day, it can be made up for.
Great. And I've got a question for you, Steve. And there's a lot of love and appreciation for you in the chat. People are really appreciative of how honest and open you've been with your story. So I just wanted to pass that on to you. But the question is just, do you have any advice or tips that you'd give to someone who's starting their radiotherapy treatment now?
Yeah, so well, I would. My thing is you go in like open-minded. As Phil says in there, they've got all the right people in there, got all the right tools to talk you through it. Never be frightened to speak to the people around you. And at the end of the day, they're there to help. And my personal journey in there, I never found any of the nurses unapproachable or any of the people regarding in that area was always very approachable, always very wanted to explain things to me. And one of the things I always say to people is the first time you go is ask the questions. Ask, don't just sit because you bottle it up and it becomes even worse. You want to know what's going to happen to your body. You want to know what's going to, you go for your tattoos a couple of weeks before and this, but get the right information and you go for the pre thing first and ask the questions. No question is wrong. No question is wrong. It's your body. You want to understand what's going to be happening to you personally. So ask the right things.
Great, thank you. And then we've just got one final question, which I think will come to you, Phil, and that is what follow-up care and monitoring will people need after they've had their radiotherapy?
So it's a PSA check primarily. You may very rarely, but some people are non-secretors, so they have very low PSAs at diagnosis. So depending on their stage of grade of disease, PSA alone may not be good enough, but generally you're seeing a couple of months, maybe 3 months after your radiotherapy with a PSA. And then again, it's department to department is slightly different, but you may then be referred into a sort of remote tracker and just have PSA every 6 months, for 5 years or so, and then you discharge back to your GP. With the caveat that obviously you've got contacts if you do have any issues to get in touch in between.
Great, thank you. So unfortunately, that's all the time we've got for this evening. But just before we go, I just wanted to bring up a second poll for everybody. Stop sharing that one. Sorry, so it always confuses me. This is the poll we want to do now. So this is how would you rate today's webinar? Hopefully you've all found it useful. I'll just leave that open for a couple of seconds. And then I promise I won't keep you for much longer after that. Okay, I'll end the poll there. So I just wanted to say a huge thank you to our entire panel, to Pat and Phil for sharing their knowledge and expertise, and in particular to Steve for sharing his personal story with us tonight. And I have been greatly appreciated by everybody listening to the webinar today. So just to finish things off, just please keep an eye on your inbox over the next few days. We'll be sharing a survey to ask how you found the webinar, and this will help us plan better webinars in the future and make sure you're getting the support that you need. So please take the time to do that. We'll also be able to share a recording of the webinar, and it will also be available from our website and on our YouTube channel. I also wanted to highlight a new service that we've launched recently, which is our Prostate Health Hub. So this is a new support and information email service that's been created to help men live well with and after prostate cancer. And like I said, it's just launched recently. You can sign up for it on our website, and one of our teams just put the link to the Health Hub at the chat there, so you'll be able to access that and sign up for the emails there. Don't forget, there's also a wealth of prostate cancer information on our website, and our specialist nurses are available Monday to Friday, 9 to 5, and that's on 0800 074 8383. So please keep your eyes peeled for more webinars as well. As Phil's already mentioned, our next one will be focusing on hormone therapy, so keep an eye out for that one. We're hoping to schedule it for around July time, but we haven't got a date set as yet. So I'd just like to once again say thank you to everybody, and I hope everybody has a good evening and take care. Thank you.
Cheers.